welcome to the Go Live Health Foundation Health Equity webinar series. Thank you to all the sponsors of the series. Today's episode is brought to you by our friends at Deloitte and Mercer. We would like to remind you that the Q&A feature is available, so feel free to send in your questions throughout the discussion. And with that, I will turn it over to our moderator who joins us from Pittsburgh Business Group on Health and Earn Staffing Solutions, Jessica Brooks-Woods.
Hello, everyone. Thank you for joining us today. I'm very excited to have this panel, Health Equity and Dimensions of Employer Influence. There are, I think, more than enough topics we can talk about just within this segment under the banner of health equity and employers and the role that we all can play. So very, very, very energized, and please be as active as you'd like to be. I'm going to do my best throughout this panel to look at the Q&A button and see who's chiming in. And if I don't get to you throughout the panel discussion, we will make sure we reserve time at the end to get to as many questions as possible. So please, we highly encourage your participation, and feel free as they come to you to put them into the Q&A function. A little bit more about myself. I serve as the president and CEO of Pittsburgh Business Group on Health, and we are a 40-year-old nonprofit business coalition comprised of the region's leading employers and nationally covering over 1.5 million lives. We work to ensure that our employers can be a partner in the healthcare industry to ensure optimal healthcare for their employees and the way people access care, the kind of care they receive, and the impact that care has on their families. And throughout the years, I've heard from employers, some at the highest level say, well, I'm in the business of entertainment or energy or education, technology, banking, transportation. Healthcare isn't my business. Like that's not my competency. Yet they feel like they're getting more and more involved intimately within how do we deliver healthcare. And that's the reality. That's true. If you're an employer, you have a responsibility to those lives. You are in the quality of life business. Each one of us is relying on our employers, including you and myself, to help us sustain a quality of life, a peace of mind that we can take care of our families for generations. Healthcare, the cultures in which we work, and the benefits you receive are an essential part of that. So I like to kick off with thanking everyone who plays an active role in being in the quality of life business, sometimes the life or death business, and certainly the joy business when we are able to optimize how we provide healthcare to those that we serve. This panel will focus largely on health equity and the dimensions of your influence, taking in the understanding that there are differences that require intentional understanding and deliberate action to create inclusive benefits, better outcomes, and enhanced quality of life for those we are responsible for. So with that, I'd like to definitely welcome and thank our panelists for joining us today. First, Dr. Terry Cooper, Vice Chair of External Diversity, Equity, and Inclusion with Deloitte Consulting. And you have a big change coming up in your life. That's very exciting. So we're so honored to have you here with us today. And Michael Garrett, Principal of Mercer. I'd like to first ask Dr. Cooper if you can just quickly introduce yourself, who you are, and then Michael, do the same, and we'll get right into it.
Thanks, Jessica. Well, good afternoon. It's an absolute pleasure to be here with all of you today. As Jessica mentioned, my name is Dr. Terry Cooper. I'm the Vice Chair for External DEI here at Deloitte. I'm actually a scientist by background. I've spent the last 35 years working in the life sciences healthcare industry, and diversity, equity, and inclusion has been a sort of a parallel role for me. What Jessica referred to is I actually will be retiring from Deloitte at the end of next week, mandatory retirement, and I'd run out of runway. So I will be moving on to some new chapters, but this whole issue around diversity, equity, inclusion, health equity will be something that I absolutely intend to remain laser focused on in the next chapter of my life. So it's a pleasure to be with you all today.
Great, and Michael Garrett here. I'm a principal in the Total Health Management Specialty Practice here at Mercer. I use he, him, his pronouns. I'm based in Seattle, Washington. been at Mercer for 6.5 years, worked in healthcare for more than 40, even though I tell people that don't look like it. My background is I have a master's degree in clinical psychology, and I'm board certified in case management and patient advocacy, which I think was a natural way to get into the whole diversity, equity, inclusion, and health and benefits. My background is in case and care management, clinical management programs, healthcare quality, been doing inclusive benefit work for about 5 years. I also serve on Mercer's inaugural Diversity Council. I've also been on Mercer's Business Resource Group for Pride, accessibilities, as well as the Racial and Ethnic Diversity Business Resource Group or Employee Resource Group. So a big fan of active participation, particularly from leaders in those kinds of initiatives in an organization. So thank you.
Thank you. Well, as you all can tell, there's a lot of passion here, quite a bit of experience, and clearly good aging techniques amongst our panelists. So I do want to start on a serious note. We came into this week, I know myself as a leader, not knowing what to do on Monday with my team, how to, what the roadmap was. And I want to start with acknowledging the lives that were lost this past weekend to violence and hate crimes across our country, both West Coast, East Coast, Buffalo being very close to me with loved ones there, and just 3.5 hours from Pittsburgh, and Laguna Woods, the Taiwanese congregation there. So we've been here before though. And from where you both sit, do you think we were better prepared to support our employees this week after these tragedies than we were after the murder of George Floyd in 2020? Especially maybe from a mental health perspective, but in any way that you feel that what's the answer from your perspective, Dr. Cooper?
Yeah, I'm happy to go first there, Jessica. I mean, we were talking about this earlier this week, and like you, my heart goes out to everybody around the horrendous tragedy that happened on Sunday. You know, one of the things that we found after the tragic murder of George Floyd was we really wanted to ensure that, in particular for our Black professionals, that we had the ability for individuals to reach out for counseling. And that's something that we had offered to all of our professionals for the longest time. But one of the things that we discovered very quickly was that all of the professional counselors that we had on staff, we actually didn't have any Black professional counselors. And it was like an incredible aha moment for us, one that we were not necessarily proud about, but one that we actually rectified really quickly. So in answer to your question, the fact that we did that back at the time of George Floyd's murder, we were certainly much better positioned this week from the point of view of being able to provide meaningful counseling. We'd also, following George Floyd's murder, established some safe place dialogue sessions very rapidly. And we learned from those the types of questions, how we should actually moderate those more effectively, really how we should let people share their emotions and be quiet at times, and really not necessarily expect always our Black professionals to lead the conversations in that regard. Sadly, we also, you remember a few months ago now, the young woman that was pushed in front of the subway train in New York, and very sadly, that was Michelle Go, who is just an incredible senior manager here at Deloitte. And that again was a call for us to say that we needed to not only have counselors and individuals that can provide support, say from a Black perspective, but also from an Asian perspective as well. And so we've constantly been on the journey around how do we make our ability to support all of our professionals more equitable every time. And so sadly, it takes some of these events to provide that wake up, but certainly we've addressed the situation.
Thank you for sharing that. And to that point, I hope the takeaway is, one, that you took action in 2020. You didn't know, but you took action and you began to iterate, and you continue to iterate, that it doesn't have to be perfect the first time. It may never be. But taking action is not an option. We have to continue to evolve as we learn and we listen. So thank you for that. Michael, anything to add to that?
Sure. I would just say a couple things, and maybe not as encouraging, but a couple things. One is what I think about what's happened in your question about behavioral health or mental health. Only about 50% of all behavioral health professionals in this country are enrolled in any insurance network. This is a huge access issue. So that's a challenge. And although virtual care or telehealth it has become an option and opened up some access, what I also find though, because we're all intersectional, is like sometimes they are not available for people with vision loss or hearing loss. So because we're not, of course, just our race or ethnicity, we're also our ability, status, and so forth, sexual orientation, gender identity. And the other piece, what this really reiterates for me is also, what are we doing for the cultural competency and cultural humility with our providers, whether it's behavioral health or medical? One of the also challenges from a workforce perspective is the low percentage of providers of color we have in this country. And so that's a big challenge. I actually just recently did some research a few months ago for Black History Month, and the only health profession in the Black community that exceeds the percentage of the overall population are Black social workers, actually, which we know that master's prepared behavioral health folks are the predominant providers. But if you try to look for Black psychiatrists or Asian American psychiatrists, like really low percentage and very difficult to get in to see them. So that plays to the need for cultural competency, I would say cultural humility, and then just holding, whether it's your medical plan or your employee assistance program or behavioral health entity, accountable for doing that kind of ongoing training and analysis of what's been the member experience and the clinical outcomes with communities of color as well. So still some challenges. I think there is an awareness, Jessica, to answer your question, on the part of employers, and there's beginning to be some changes in how we manage those provider networks for behavioral health as well as medical.
Thank you. I mean, we want the good, bad, and the ugly. We want to know where we are and where we need to go. And that topic of representation is so important because it's normal for us to want representation. I've asked for female OBGYNs, right? I've, looked for Black doctors for my kids, or a Black dentist. It's not a man. My husband asked for a male. It's not uncommon to want to have representation. There's some from the caregiver that represents you, and the representation issue is major, and that's a long game, which we need to emphasize. But so how do we emphasize the identity or because it's hard to find, unless it's word of mouth and your cousin or your sister told you, it's kind of hard to find in the health plan directory or any directory from a vendor. So how do we address that with setting the expectation that in the short game, you can take action on cultural competency building? What is that conversation with our vendors and partners?
Sure, if I could take this one. I think what you're referencing sometimes is called patient-provider racial concordance and patient-provider gender concordance. And there's actually studies that show that when you have that racial concordance, the member experience is almost always very positive and may result actually in better clinical outcomes. The same with gender concordance for members who identify as female when they have a female physician. So one is just making sure that you talk to your vendors like this is important. And I would say the medical carrier, the dental carrier, the vision carrier, your EAP. I think some of the national medical carriers are making a lot of progress around getting the identified race and ethnicity into provider directories, but it takes a village. It takes all these employers to be talking about that. I think another idea that just popped in my head is July is National Minority Mental Health Month, and having webinars for your own employees around that, and sometimes just highlighting what benefits you have. You know what I mean? Like maybe people just unaware. And actually also going to your EAP to find out, do they have education modules for employees of color or other underserved communities to support them in, surviving a hate crime or microaggressions or macroaggressions and so forth. So really optimizing what you have currently in the benefit plan and giving notice to providers that you want this kind of design in their service offerings. Dr. Cooper?
Yeah, I mean, I think you summed it up beautifully. I mean, the one thing I would emphasize even more, Michael, and I think you hit the nail on the head, is that many employees are not fully aware of what the employer does have to offer, because those plans are constantly being updated, etc. And I know at times we have some challenges in that regard with our sort of 110,000 employees, is actually making them aware of the fact that our benefits have been updated and that these services are available. So I do think it's iterative. You need to constantly look at it, but also there's a really strong need to be communicative about it and not just assume that people are aware of what's present.
Those are all great points. So we're assuming everyone here understands what health equity is just because they're on this webinar, but it can sometimes be an abstract concept for employers. And I know many of my members, it still is, there's a spectrum of where people are on this journey. Can you frame what an equitable health benefits ecosystem looks like to you? I think we covered some of it, but can you go a little bit deeper on what does an equitable health benefits ecosystem look like? What are the characteristics of it?
Mike, would you want to go? I'm happy.
Yeah, I can do that. So first of all, I would step back, Jessica, and frame the whole conversation by saying over 20 years ago in the Institute of Medicine's report, Crossing the Quality Chasm, they identified 6 aims of a high quality, high functioning health system. So safe, timely, effective, efficient, equitable, and patient-centered. So think of it as STEEP with an extra E. Safe, timely, effective, efficient, equitable, and patient-centered. And so I would also just say that Medicare and Medicaid plans are further ahead, frankly, than commercially insured plans in identifying and addressing equity, because the Centers for Medicare and Medicaid Services and Medicaid agencies have said this is important to us, and we want you to develop and implement health equity initiatives. And I think the employer community that pays for half of the healthcare in this country can do that as well. So I just want to frame like equity is one of the 6 aims of a high quality system. And how the Institute of Medicine described it is that there's no variation in the quality of care based on any personal demographics. And I think of it in 3 buckets when we talk about health equity. One is access to care. So that means geographic location. It means accessibility for people with vision loss and hearing loss and limited English proficiency. So the whole access issue, and also benefits that are accessible. So if you're a parent of a child with special needs, like, do you have the full array of therapies available without limits to meet all the healthcare needs of your child, or for yourself if you have a disability? So that's one bucket. The next is the patient or member experience, both with the health plan benefit vendors or whatever benefit vendors, and with the healthcare providers. And the third bucket is clinical metrics. So that's looking at, for example, preventive screening rates. Are you looking at preventive screening rates, colorectal screening, mammography rates, prostate exams, and so forth, through the lens of race, ethnicity, and other demographics, or chronic care, adherence to chronic care guidelines? So diabetes, asthma, hypertension, are all of your members, again, through various demographics adhering to that. And then health service utilization. So hospital admissions, hospital readmissions, emergency department visits, and so forth. Again, through the lens of not just gender and age, which is what we historically have had in health insurance, but through race, ethnicity. That's where some employers are starting, Jessica. And then maybe down the road, sexual orientation, gender identity, disability status, veteran status, and so forth. But you've got to have the data on your membership to find where those disparities are, and then working with your benefit vendors to launch health equity initiatives. And particularly, I'm thinking of medical carriers, but it could also be, your dental or other carriers too that offer healthcare, so digital health services or apps that you have, and so forth. So those are some how I would frame health equity.
Yeah, I love the framing. I think it's absolutely perfect. The one thing I would say from the point of view as a large employer, you can't make any assumptions around exactly what are the benefits that your group of employees need. It is absolutely critically important that we get to the granular level to actually address every one of our employees. So from our perspective, we have spent an inordinate amount of time really trying to understand the unique requirements, whether it relates to gender, sexual orientation, race, ethnicity, physical disability, veteran, etc., and have really tried to recognize that we need to break it down to that granular level and not to make any assumptions. And that's where we call them our business resource groups or in our communities, but that's where our business resource groups have also had an enormous role to play, which is to actually be part of that dialogue with our talent organization, with our benefits organization, so that we can constantly ensure that they're aware of the needs of our young professionals. You know, we're a little different from many organizations in that 80% of our professionals are millennials or younger. And so they're constantly keeping us on our toes as it relates to their needs. But I would say, you know, it's so critically important not to assume, but to actually really engage to understand the needs and then to continually adapt those benefits accordingly. And that enables us to actually put some of that pressure on the providers that you were talking about, Michael, because we have the hard and fast data around our professional community as to specifically what their needs are and their requirements.
I think that's really great. And I've actually done listening sessions with business resource groups or employee resource groups and totally agree. You need to hear the voice of the employee. And I actually have one major client that identified 2 years ago, actually because of the issue of lack of the ability of a member to find a racially concordant provider, and also the mistreatment of transgender patients in a particular health system, launched a sole focus on health equity as their sole strategy with guiding principles and values and assumptions. And we now actually have developed a tool and a process to evaluate new benefit offerings and so forth. And they've identified their prioritized populations. And we have member advisory committees. And so we screen these decisions or these policy and operational decisions from with that health equity lens. And then I say, you know, our Mercer actuarial, we have a sea of actuaries at Mercer, and they can look at the financial, but we've never looked at benefits from that lens of a member and the range of members in terms of how that impacts them. So I think that's all good stuff. Yeah,
I totally agree. I love that you brought that up. As I speak to many of our members, especially earlier in 2021 and later 2020, they were largely aware of health disparities and health inequity. It wasn't like new to them, but it wasn't anything they felt they were to focus on, or they didn't know how that translated into their workforce. There were a lot of myths or misunderstandings that this was like an unemployed issue or a Medicaid plan issue, and not commercially, as if, you know, the paycheck addressed that altogether. And but what they shared was qualitative data is just as important as quantitative data. However, they weren't hearing the stories. They said these stories aren't coming to us. And I don't know if they're going to the health plan. If they are, they're not coming to us from the health plan. I don't think they're going to the health plan. It was like, where are these stories? Because I, as a benefits practitioner, need to be able to use those stories as well as I influence our commitment. So how do you just, you know, real quickly on build trust so that you do get that qualitative insight? How does one achieve that?
A couple things. One is I have had multiple experiences, Jessica, where the benefit leaders in an organization have never worked with a chief diversity officer in the organization.
That's
like
right.
It's sort of unfathomable to me. So first of all, if you're a benefit leader and you have a chief diversity officer, meet with them and come up with have the dialogue of how can benefits support the overarching DEI strategy within the organization. The other piece that I've found is that benefit leaders are unaware and do not have any communication with the business resource groups or employee resource groups or the diversity council. Like, create a dialogue, have listening sessions in a structured kind of way, And, employers can do that themselves. They can have a consultant help. Just get the dialogue going and they will tell you. They will tell you what's important. So those are just a couple of very concrete examples. And I've just learned not to assume that the benefit leaders are having those kind of dialogues, and benefits tend to be a little bit further behind the rest of the organization. And you need to have that alignment.
I'm so glad you mentioned that. Part of the new team for a health strategy includes your D&I practitioners for sure. Yes. Any other procurement, any other kind of, other team members that should be a part of this new equitable health team? Procurement
and supplier management as well. Absolutely. So as you look at health and benefits or other things, you're looking at supplier diversity. So minority business enterprises, women business enterprises, veteran-owned business, disability-owned business enterprises. So all those. And then I was also say, benefit leaders and HR can also promote external accreditations. For example, like the Human Rights Campaign Corporate Equality Index, which has been around for 20 years, Disability In and the National Organization on Disability for disability inclusiveness, EDGE certification for gender pay equity. There's a number of them out there because employees are looking, Dr. Cooper, when you were mentioning you have a lot of millennials and Gen Z, studies have shown that members of those generations want to work for organizations that demonstrate diversity, equity, inclusion, even if they are not a member of an underserved population. Exactly. They're looking for that. And right now, as we know, it's an employee market. And so demonstrating that in a very meaningful way, I think is important.
Yeah, I mean, you've summed it up beautifully. You're absolutely spot on. I mean, there's that element around the talent war. So even though this is the right thing to do, you actually have to do it if you're going to continue to attract the best talent for sure. Yeah.
That's right. Well, we actually have some audience questions coming in. So I'll go to the first one. Jonathan is asking, how many employers are collecting necessary equity indicators, race, gender, identity, in order to create employer-specific analysis? How are they achieving this data collection? Employee surveys, onboarding questionnaires, integrated into eligibility systems? Are employers actually collecting this data? What type of data? And then what are their collection mechanisms?
So Jessica, I think there's been a major change amongst many organizations over the last almost 18 months, 2 years around the type of data that they're now collecting. We have seen a significant increase, and I'm sure Michael's seen this as well, in the number of companies that are actually reporting what they refer to as their transparency reports. And actually Deloitte, we actually published our own transparency report for the first time 18 months ago and are about to launch our second version in the beginning of June. And that was our first opportunity. It was almost like this data was so closely guarded internally. And this was the first time that we opened up the kimono and basically said, we're going to share our representation data from a gender perspective and across all levels. We're going to share our racial data, our ethnicity data. We actually do have some fairly specific data around our LGBTQI population, veterans, etc. And that was a first step for us to be able to actually share openly, both internally and externally, what the overall representation at Deloitte looks like. And we've seen many, many other companies now taking that as a lead. There is one element around that, though, Jessica, which I'm sure you're completely familiar with, and that is that many organizations, when individuals are employed and when they fill in their first sort of onboarding documentation, quite often employees only have a limited number of questions that they will ask the individual. And it's really down to the individual as to whether they want to actually provide a lot of that data. They may only want to provide their gender data. They may not want to provide any data on race, ethnicity, etc. And so in order for us to really truly understand the makeup of our organization, we had an enormous push around self-identity as well. From the point of view that we went back, we increased the number criteria against which people could evaluate themselves, and really tried to make that as meaningful as possible in every area. But more importantly, truly encouraged individuals to be more open around their own personal identity. And we were able to communicate why that was so important. So it was really important from the perspective of looking around our overall ability to provide the best talent experience, and benefits was an integral part of that. But also from the perspective of thinking about how we can continue to drive greater allyship as well. And so when individuals went back in and were now able to actually provide more data around gender, sexual orientation, race, ethnicity, we broke down Asian, which was one group for the longest time, into Southeast Asian, South Asian, etc. We did a lot of work around the LGBTQI classification, etc. as well. But we also provided an opt-in, opt-out. And so if people opted in, then we were in a position where we could really share that data more broadly. And that has provided us with a significantly more accurate insights around our representation. And then we can actually say, we can really work with benefits in order to do that as well. But I can't stress how important it is to truly have that appreciation of the representation of your organization, and also that ability to understand the voluntary turnover as well, because a lot of that, we actually reported on that as well across the groups, because it highlights where we need to lean in even more. And candidly, benefits can be part of the challenge from that representation turnover as well.
I think those are all really great points. I think when I'm asked about this question, which I get asked this a lot, Jessica, I first of all talk about why are we doing this, and to assuage the concerns of employees of saying this is going to be used on a population health basis, not in an individual, like, hey, Jessica, why didn't you get your XYZ service? That's not the point. So I think to Dr. Cooper's point, like, why are we doing this? It's population, it's not aimed at a specific individual. So that's really important to articulate why you're, and really to identify health disparities and to initiate health equity programs. This more specific question, I would say that employers are starting to add race and ethnicity because that's typically been collected on a voluntary self-identified basis at the time of hire. So that's what some employers are doing, but they have to work through sometimes the legal issues. If that's not possible, I've also seen a lot of the major medical carriers are imputing race or ethnicity based on the residence of the individual. That's an imperfect way of doing it, but if they can't get the data, they're trying to come up a way to identify race and ethnicity. So what I see is a multi-year approach to this. So starting with getting race and ethnicity into a database to be able to see health disparities based on those three buckets I mentioned: access, experience, and clinical metrics. And then I see sexual orientation and gender identity maybe coming down the road, and then other kinds of data being implemented. So this is so-called REALD data: race, ethnicity, languages spoken, disability, and then SOGI data: sexual orientation and gender identity. Part of it is the comfort level with an employer around that. And I think particularly things like sexual orientation, gender identity, and disability status could be particularly sensitive. So back to talk to your employee resource groups or business resource groups about how to do that. There's some great guidelines on, for example, sexual orientation and gender identity, about how to ask the questions, how not to ask them.
Okay.
I would also say for employers, there's a different categorization than there are for medical providers. So it depends on where you're at. So that's what I'd say: multi-year project, talk to your employee business resource groups, making sure that you're emphasizing this is a population health approach, not an individual, singling out an individual person.
Thank you. Both of those answers were completely comprehensive. It's interesting, as we talk about the idea intersectionality and how do you start, where do you start? And it's a challenge to be inclusive without being dismissive of any one group, but you have to start somewhere. and some places are lower hanging fruit because we have in some parts of our organization collected data, like EEO1 data is collected on a part of our HR organization, just that hasn't traditionally been integrated with claims data or utilization data. But that is, I think, a challenge is where employers have been in the, especially from a benefits perspective, probably from a variety of other perspectives, in the equality business versus an equity business.
Yeah.
And equity does say, well, we will have to make some decisions here, some differentiated decisions at that point, or approaches to actually create equity. And they're not used to making things different for any employee, same co-pay, co-design, et cetera. And that's just an uncomfortable place. And what we're hearing is that's equity. There is a difference between equality and equity, and we do have to start somewhere. And sometimes it's easier with the places where you have data already and you build a journey over time. So there are several questions coming in. So another question is, have you included genetic testing to address racial and ethnicity impact on risk and identification of best treatment? The precision medicine question, in a way. Where does genetic testing, if at all, is it coming into identifying best treatment, and are those being integrated into plan designs or other policies?
Well, that's a really technical area. I would say, first of all, I'm not sure that I'm qualified to comment on that. I would say that clinical research now has had a growing awareness of the need to include race, ethnicity, sexual orientation, gender identity. Actually, my older sister is a registered nurse and a clinical research coordinator, and she and I talk all the time about that. I think there's a growing awareness of the need to make sure that clinical drug trials and other clinical research are incorporating all the different demographics when they do analysis and study. But I do not have a specific answer to genetic testing. I haven't come across that.
No, and I'm with Michael there. I mean, my only experience really has been on a personal level around having the genetic testing around, certainly with my husband right now has been diagnosed with a form of cancer, and having that genetic testing in order to ensure that the best treatment is identified in that regard. And I've seen more and more of that, obviously from the perspective of many of our women with breast cancer as well, looking to determine whether they have the HER2 gene or not, etc. But so I would see that as genetic testing becomes more and more affordable, I would see that increase substantially. But that's really just my own sort of like personal experience. I'm not an expert around that area.
Yeah, I would agree. I mean, I have heard this question coming up more, and I think the area of diagnostics will be playing a larger role in being more precise into who should have which treatments, or which treatments should you start out with based on your genetics or other diagnostic tools. So I do see this being a bigger part of health equity. I think it actually should be, but I would agree with you that it's not a mainstream strategy. People haven't dreamt from, should we be talking about health equity, to genetic testing yet. But I do see it playing a bigger role over time. All right, next question. Well, first, compliment, great information. You mentioned trust. There is still significant stigma around mental health issues, stress, PTSD, which is a part of identity. What has been your experience in brokering a safe space for exploring benefits, for example, and perceived disclosure, privacy, et cetera? How do we address the stigma and PTSD, et cetera, mental health as a part of identity?
Well,
Okay.
Sorry. Several things. One is, I think it's really powerful when a leader talks about their experience with mental health, whether it's themselves or their family members. And I use the word behavioral health to include mental health and substance use disorder both. So making sure that we talk that it's both. So that's the first thing. And having people talk about it, having a whole campaign within an organization, things like it's okay not to be okay. I mentioned already, July is National Minority Mental Health Month, having events around that, or I think September is Depression Awareness Month, and so forth. So I think all of that communicates to someone that it's okay to talk about mental health issues. The other issue is that there are certain communities that there are bigger stigmas around mental health than others. And so that's trickier. Again, I would say talk to your ERGs and BRGs. They're not supposed to do the work for you, but they can tell you what would be helpful for them. And then also, I'll just go back to promoting. If you have, for example, a behavioral health provider network that does allow you to select by race or ethnicity, you do have an employee assistance program that has information around dealing with racism and micro and macroaggressions and so forth, becoming an anti-racist, like promoting that more and more. I think, again, telegraphs, if I can use that word, an outdated word, that you as the employer are concerned about that and want to offer up services and supports for people around mental health. So those are just some things that I would mention.
Yeah, no, I mean, I think, Michael, you're spot on. I mean, we've really been trying to promote mental health and empowered well-being for a significant number of years now. We actually do have a chief well-being officer who is really focused on the continually thinking about ways in which we can address mental health for all of our professionals. You know, we know that has become an enormous issue over the last 2 years. You know, I just was looking at a report that we were around women in the workplace, and, you know, almost 60% of women now in the workplace are even more burnt out this year than they were last year. So this continues to be a significant issue. And you're absolutely right. You know, we have a very large veteran population here at Deloitte as well, and many others. But this ability to recognize mental health, to talk about it, to have leaders to talk about some of the challenges that they faced, etc., and having that open dialogue has been really meaningful. So we have a major push once a year in May around Mental Health Month, where we really focus on trying to get as much of that messaging out as possible, really emphasize again the benefits that we have there to support, but also for individuals to really share the story, their personal stories, so that others can identify with that and feel more comfortable actually coming forward if they need help, and also creating that safe dialogue. This is one area where I think around the pandemic in particular and everything that's happened, that this is where organizations absolutely need to lean in more and more. It's an area that I think we certainly recognize that we need to be very cognizant of at all times with respect to our professionals in that regard. But again, I think it's leading by example, and having key leaders in particular share their challenges and their stories as well.
Yeah, and I was just thinking too, the way I think about behavioral health is in kind of 4 domains. First is prevention. So, you know, there's mindfulness apps and coaching and those kinds of things that are available. Then there's screening for behavioral health. And I think screening should be done by the medical carrier, the disability carrier, your EAP. Like we have now reliable and valid tools to screen for behavioral health conditions. And then what are these different benefit vendors doing in the benefit ecosystem when there's a positive test for a behavioral health condition? The next is the treatment part, and which I've already talked about, having diverse provider network, cultural competency training, and accessibility. And the fourth, actually, that sometimes gets overlooked is the return to work. And I'm a really old rehabilitation counselor. And so the employer community is typically familiar with accommodations for people with, you know, musculoskeletal kinds of issues, you know, sit-stand desks and chairs and so forth, but not as in my experience, not as sophisticated in return to work for people that are coming back after a mental health or substance use disorder, or an individual coming back after a dependent that's had substance use disorder or mental health, or suicide attempt. And so really getting into how do we help individuals come back to the workforce after they've had that kind of episode or experience. So the 4 buckets: prevention, screening, treatment, and return to work.
Thank you. Hopefully that answered the question. Let's see here. How can employers with dispersed population ensure equity of health benefits across their teams? They gave examples of full-time versus hourly, or rural versus urban. As an example, I even hear from global employers who share that they realize even more now that healthcare is local, but they have folks all over the country in various markets and even across the world, and approaching health equity, understanding that their populations are experiencing things differently is something that they're up for the challenge for, but definitely need help. So how can employers with dispersed populations ensure equity of health benefits across the board?
I mean, I think the first step is for employers is actually to determine what do they want to be known for, like what is the benefit program that they want to provide, from the point of view. So I look at it from the perspective of thinking, what are the absolute core benefits that we as an organization really determined to actually deliver to all of our employees. Now, it's a little different for me, and so I'll turn to Michael here, because we're a professional services organization, so we don't have necessarily all of those different part-time employees, urban, etc. But I do think it's really important to have a foundation upon which this is the absolute minimum, and we want to ensure that we have that equitably available for all of our employees, and then to think about what we said before around what are the needs of those individuals and how do we actually drive that forward. But as I say, I'm not an expert in the different subgroups, but I know, Michael, you do work across that. So
yeah, so a couple things. One is when you do your analysis of a provider network, looking at the geographic location and coming up with standards of access to both individual practitioners and facilities so that that geographic issue is dealt with. The other issue is it's a double-edged sword. I think virtual care has allowed more access, at least in theory, to medical and behavioral health providers. The challenge is that people live in rural area, and I actually grew up in a rural area, is broadband connectivity in rural areas and in some urban areas is not so great. So trying to figure out what are the bandwidth requirements, particularly for digital health apps or website or what have you, I think that's important. The other piece in terms of equitable access, sticking with virtual care for a second, is there's all different kinds of virtual care, right? That you can get care through an app, you could do texting, you can do phone and video. There are variances in the preferred communication methodology that different racial and ethnic groups have and certain genders. So for example, a recent study that came out showed that Black patients preferred telephonic interaction and did not prefer the use of an app in using digital health apps. Not sure why that is a variance, but what that just tells me is a multi-channel strategy for supporting people with virtual care. And looking for the issue around broadband requirements and having that as low as possible so that people with broadband connectivity issues are not an impediment. And I would just go back and say, listen to your employees also. One thing I didn't cover is the full-time versus hourly. That's a decision, setting aside the regulatory requirements. Do you cover part-time people, and at what level do you cover part-time people? The other thing I would say is I was dealing with an employer, and we were talking about doing a DEI, a benefit vendor assessment, and they said, well, only about half, a lot of people are part-time and only about half people have access to their medical plan. And I said, well, what about your EAP? I said, well, anybody can do their EAP. Like, it is if you're 5 hours a week or 40 hours a week. So I was like, oh, well, then let's focus on the EAP. Like, I had never thought about that, honestly. And particularly supporting not just behavioral health issues, but potentially financial issues or other kind of social issues that they might need. So leveraging that also is an idea that I would put out there.
Thank you. Thank you. We have a couple of more questions. The unexpected overturning of Roe v. Wade will likely lead to greater health inequities. What steps would you suggest employers take to be ready to support their employees following this change? Michael, would you like to start?
Well, I want to be careful here, but I would say start with talking to your legal counsel about what you can do. because it gets very tricky if you have a particular state where not only abortions are illegal, but traveling to an abortion might be illegal. And so you have to really start talking to your legal counsel around that. And there's other issues around states banning gender affirming hormone therapy, for example, for transgender and gender non-binary dependents. So I think you first have to start talking to your legal counsel, and then you make a philosophical choice. You know, so some large employers that are saying they will pay for travel for those states that ban abortions or other medically necessary service. They'll pay to travel. Think of it as like a traveling to a centers of excellence. Like maybe the center of excellence is not in your state, but it's another state, and typically employers will pay for travel and lodging to get to those services. But it's just tied up with a lot of legal issues, and I'm not an attorney, so that's why I would defer to that. Dr. Cooper.
Yeah, no, I think I was going to say exactly the same thing. I mean, the first thing is really from the point of view of seeking that legal advice, because much as you may want to do a lot more as an organization, this is just so complicated at the moment. So I do think actually seeking that legal advice and determining what can happen. The other thing I would say, though, is I do think it is important to maintain a level of communication with your employees around what you are doing or not, as the case may be, because I think silence is not good either. And even if it's from the point of view at this moment in time, we're continuing to evaluate the situation, etc. We're looking for legal advice, etc. At least that provides your employees with comfort that you're actually addressing the issue, and that it hasn't disappeared into a box that nobody is looking at this moment in time. That's what I'm hearing from so many of the people that I talk to, is that at least that they feel that there is a dialogue around the situation, even if companies don't have all of the answers right now.
Yeah, I think you brought up great points. I too am hearing from employers who are starting with their vendors and asking the questions, their PBMs, saying what drugs are actually should be covered or can be covered to support employees and family members. The travel component, they are looking at a travel benefit, and they also are doing it in a delicate way. They may have board members who are on one side and some on the other. Their CEO may be in one place, but their chief HR officer in another place. So those benefits leaders are in very difficult positions, philosophically even, and may be divided or different within their organizations. So they're starting with asking their vendors questions, their health plans, the medical carriers, understanding the laws, to your point, in the different states that they may have employees, and really figuring out what can they do before determining what they are going to do. So a lot of discovery right now.
Yeah, I just thought of something else too that I've actually recommended. If you're an employer and you currently have, like, for example, a maternity management program, whether within a health plan or another vendor, or if you have a fertility vendor, ask them, what has been their approach when a birthing parent goes through the process and chooses to have an abortion? Do they support that? I just was meeting with a fertility vendor, and they were like, "Oh yeah, we're developing our point of view on that." I'm like, "Really? You're just now developing a point of view?" Like, and for whatever reason that the birthing parent chooses to do so. So I would actually start with that too, like doing an assessment of your current vendors that impact birthing parents, asking them their point of view, setting aside the whole laws that are being passed and so forth. If you have a member going through that solution, and with education and support, what's their stance?
Great, that's a great suggestion. Tammy, thank you for the compliment. She said excellent on top-down openness. That, I think that was during our mental health conversation. And then another question is, with privacy issues, I know companies can't see mental health utilization, but have any companies seen an improvement in employee morale and attitudes, engagement at work after offering mental health services? Well, one, is it true that we can't see mental health utilization?
No. For fully insured plans, that's true.
Yeah, I thought I've seen mental health. Okay.
But I do think we have seen, the reports that we've had where we have really lent in, and particularly in certain situations, for example, around the tragic murder of George Floyd, what happened in Buffalo at the weekend. So, you do see that individuals are more willing to open and talk in, and certainly from the perspective, actually, it has lifted the morale that individuals know that there is a support mechanism, and one that we are very active in providing for them.
Yeah, I would answer the question a little differently, Jessica. Maybe this is not, but I actually had a very large client that switched their behavioral health network. And the new network really focused on getting more and more outpatient behavioral health providers. And what we saw was an increase in outpatient behavioral health providers and a decrease in inpatient and residential treatment. So, and I love to make our actuaries nervous. It's like, we need to get more behavioral health claims coming through. And we proved that even though that the outpatient behavioral health increased substantially, the overall cost of behavioral health decreased because there were fewer psychiatric admissions, residential treatment admissions, and so forth. So, so that's one comment just on utilization and cost. The other is, if you're going to look at employee morale, I would strongly suggest asking on a voluntary self-identified basis, race, ethnicity, gender, et cetera, so that you find out it's not just a generic, what's the experience, but for specific communities within your organization.
Yeah, the one thing I would add there from the point of view is coming out, when the pandemic hit, we actually surveyed really frequently from the point of view around individuals' mental health, because we recognized very rapidly that mental health was one of the significant challenges that our 110,000 employees. And so we would constantly, early on, we were doing it almost every 3 months to actually track where individuals are. And that wasn't just, Jessica, to necessarily address benefits, but there was a big piece of that around what more should we be doing to actually ensure that we were maintaining a healthy workforce in that regard. So asking specific questions, the stress levels, the things that they were really struggling with, and then actually, again, trying to adapt the benefits that we provided to alleviate some of those pressures was really important as well. And when we did that, and then we would start to say things like, from the point of view of morale, or are you likely to leave or stay, etc., we saw an increase in the engagement of our professionals, because we were actually actively seeking to ensure that their mental health, that we took to be able to articulate that we were taking that seriously.
Thank you. Believe it or not, we were at the top of the hour. This has been such a dynamic session. One of the quotes that I really inspires me and keeps pushing me in this hard work, and oftentimes it's difficult work, but it's definitely purposeful work, is from Martin Luther King Jr. from 1966. And he says, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." Yeah. And each one of you, thank you, Michael, thank you, Dr. Cooper, and all of the panelists or audience members who were actively engaged, took notes, stayed for the hour, are playing a part in addressing that injustice. And that is the greatest gift that we can leave as a legacy. So thank you all. Thank you for having us, and we will close out the panel.
Thank you all. And thank you, Jessica and Michael. Pleasure to join you today. Thank you.
I'm here too. Thank you.
Thank you to Jessica and all of our speakers. Please visit our website at hlth.com to catch up on all Health Go Live webinars. And join us in Las Vegas, November 13th through 16th for Health